Hi, everybody, and welcome to this next installment of the American Society for Preventive Cardiology CardioCore Lecture Series. I'm Anne-Marie Navar. I'm the current secretary of the ASPC and an associate professor of cardiology and a preventive cardiologist at UT Southwestern Medical Center. I am absolutely delighted to introduce my very good friend and brilliant expert, Dr. Neha Pagidipati, who is going to be giving our lecture today. Dr. Pagidipati is an associate professor of medicine and cardiometabolic disease prevention specialist at Duke University and the Duke Clinical Research Institute. Dr. Pagidipati has an MPH from Harvard and did her internal medicine residency at Brigham and Women's before going to Duke for a clinical cardiology fellowship and a research fellowship at the Duke Clinical Research Institute. Currently there, she directs the Duke Cardiometabolic Prevention Clinic, and her research focuses on cardiometabolic disease prevention with a particular emphasis on lifestyle, weight, lipids, hypertension, and diabetes. You've seen her research in all of the major journals spanning clinical trials, outcomes research, implementation science, and her ultimate goal is to improve evidence-based care for patients at high cardiovascular disease risk. Dr. Pagidipati is also the Associate Program Director at the DCRI for their research fellowship. Please join me in welcoming Dr. Pagidipati as she presents our lecture, Diabetes and Cardiometabolic Risk Management.
Well, thank you so much, Dr. Navar, for inviting me to be a part of this CardioCore series. This is a huge honor for me, and it's especially an honor to be able to do this with you, given that you are one of my closest friends, and anytime we get a chance to do something together, I'm super excited to do it. So thank you all for having me again to talk about diabetes and cardiometabolic risk management. This is one of my favorite things to talk about. These are my disclosures. And so what we'll briefly cover today is actually a massive topic. And so there's no way we'll get to all of cardiometabolic risk reduction in patients with diabetes, but my hope is to give you a general sense of my approach, how I do this every day in clinic with patients. And then I hope in the discussion and in the Q&A, we really get to some of kind of the tougher questions of what therapies do you start when, and we get to some of those details that are really relevant in everyday clinical practice. So we'll start with talking about CKM staging, risk assessment, risk modification, and then really end with the importance of interdisciplinary care for this patient population. And so the way that I'd like to start thinking about my patients who come to me with diabetes and, I'm thinking with them about ways to improve their overall cardiometabolic health and prevent them from developing overt cardiometabolic disease. Increasingly, I am trying to put these patients in the context of the CKM staging. Now, many of you will be aware that in 2023, the American Heart Association put out a presidential statement around this concept of cardiovascular kidney metabolic syndrome. And it really is this kind of spectrum of comorbidities in the cardiovascular kidney and metabolic space that overlaps so much and requires us to think in a much more holistic and interdisciplinary way about these patients. And the reason that I'm really encouraging people to think about their patients in terms of where they are in the CKM stages is because there are going to be a lot of guidelines and recommendations that are going to come out that are going to be based on CKM staging. So the earlier we all start to get used to thinking about where patients fall in the CKM spectrum, the easier it's going to be to implement the upcoming guidelines in our practice. So just as a reminder, for CKM stage 0, this is primordial prevention. They have no risk factors, and we're trying to avoid them developing any risk factors. By stage 1, they have excess adiposity. They have obesity, but they don't yet necessarily have all of the other things that can come along with that. That starts in stage 2, where they have metabolic risk factors. Maybe they have hypertension, hyperlipidemia, metabolic syndrome, the development of type 2 diabetes, and there may be some kind of moderate to high risk chronic kidney disease. By the time they get to stage 3, they have subclinical evidence of cardiovascular disease in CKM syndrome. So that could be subclinical atherosclerosis, that could be subclinical heart failure. And again, they could have high risk chronic kidney disease as shown down here below. And then by the time they get to stage 4, they have overt cardiovascular and kidney disease. They have coronary heart disease, heart failure, peripheral arterial disease, stroke, atrial fibrillation. So this is how we can think about our patients with CKM syndrome. And for the purposes of this talk, I'm really going to focus on patients with diabetes. So by definition, they're stage 2 or more if they have type 2 diabetes. And a lot of what I'm going to focus on is patients who have not yet developed overt cardiovascular disease. So they're really in the stage 2 to stage 3 phase. Now, for these individuals who are in the CKM stages 2 and 3, again, type 2 diabetes, other risk factors, maybe they have subclinical disease, but have not yet had a heart attack or stroke or overt peripheral arterial disease, I am thinking about using the prevent risk score in these individuals. Again, the prevent risk score, which kind of came out alongside in the last couple of years, is for adults 30 to 79 years old who do not have known cardiovascular disease. Again, no known heart attack, stroke, peripheral arterial disease, revascularization, but it excludes individuals who have HFrEF, who have a coronary artery calcium score of greater than or equal to 300, because essentially those individuals should be treated as though they're secondary prevention. And then it also excludes patients with end-stage kidney disease. And so the website that I've listed here is the Prevent Calculator. And again, it's important to remember that the Prevent Risk Score was developed with a more diverse population, which I think is really important, a younger population, a contemporary population, and it has the capability of doing a lot more than the prior risk scores in that they can be used to predict both 10 and 30-year risk. Again, that's extremely important, especially as we're thinking about our younger population. Our younger patients may have significantly high lifetime risk or 30-year risk, not that great of 10-year risk, but we want to know that. We want to be aggressive about treating them. And then also the prevent risk score includes not only atherosclerotic cardiovascular disease, but also a score to predict heart failure, which is extremely important. Now, what you can see here are the variables that go into the various prevent risk scores. And what you can see at the bottom is, there's the basic score that includes age, sex, lipids, blood pressure, et cetera. But then you can add some additional variables that will give you even greater specificity in terms of your risk assessment. And that includes UACR, urine albumin to creatinine ratio, hemoglobin A1C, and zip code. And especially if we're thinking about our patients with diabetes, especially that UACR and that hemoglobin A1C are going to be very relevant for them. Now, the cutoffs that are associated with the prevent risk score for treatment of blood pressure, cholesterol, and so forth are forthcoming. We don't yet have all of those exact thresholds. We expect them to be coming in the lipid guidelines that will be released later this year, and in the CKM guidelines that will also be released later this year. So stay tuned for those, but these are the risk scores that I am using in my clinical practice. But beyond the risk score, we know that any given risk score does not include everything you need to know about a patient. There are other potential risk enhancing factors or risk modifiers that we also want to take into account, particularly in our patients with diabetes, to make sure that we are getting as full a picture of their overall cardiovascular and cardiometabolic risk as possible. And so I'm not listing every one of those risk modifiers here, but I'm going to list some. These are ones that are diabetes specific. And I took this from the 2018 cholesterol guidelines. So it's really important to know how long your patient has had diabetes. If they've had type 2 diabetes for greater than or equal to 10 years, that is a hugely prognostic risk factor, and not in a good way, or to greater than 20 years for type 1 diabetes. So that's a really important thing to keep in mind because it is very particular to patients with diabetes, but it's also a highly prognostic factor. In addition, if they have albuminuria, and that means anything greater than 30, and their UACR, that is a poor prognostic factor. Obviously, an eGFR that's less than 60. If they have retinopathy or neuropathy, even though that's microvascular disease, that is associated with worsening cardiovascular morbidity and mortality. And then same with ankle brachial index, it's abnormal, less than 0.9. That's of course associated with peripheral arterial disease, which is also associated with just global atherosclerotic cardiovascular disease. So these are diabetes specific risk enhancers. But we don't want to forget all the other stuff that's important for our broader patient populations as well. And in addition to body mass index, we really want to be thinking about ways to measure visceral adiposity. The Lancet Commission on Obesity that came out just last year really emphasized the importance of other anthropometric measures of adiposity, not just BMI, which doesn't do a great job of taking into account visceral adiposity. Things like waist circumference and waist to hip ratio are extremely important, especially in certain populations. For example, like South Asian populations. We know that those populations may have a normal BMI, but have significant visceral adiposity that puts them at risk for future cardiometabolic disease. And then, of course, there are other lab-based factors. Apolipoprotein B, which essentially is the LDL cholesterol particle number, is one of the single greatest and most prognostic risk factors that we have, and it is certainly more predictive for cardiovascular disease than LDL cholesterol concentration alone. So it's really important to think about that, especially in our patients with diabetes who are at risk for having a discordance between their ApoB and their LDL cholesterol levels. Lipoprotein little a we'll talk about in a few moments. HSCRP, we know from the Jupiter trial that individuals with, even in primary prevention, who have an elevated HSCRP are at greater risk for future cardiovascular disease and can certainly benefit from statin therapy. We talked about UACR and EGFR, and then we're also going to be talking about the FIB4 score. We don't, as cardiologists, always think about the liver, but we got to. And so this is going to be something that we are increasingly going to need to be aware of. Additional risk modifiers are history-based. So if your patient, I mean, in my opinion, one of the strongest risk factors for future cardiometabolic disease is if your patient has a family history of premature cardiovascular disease, meaning that they have a first-degree relative who's a male less than or equal to 55 or a female less than or equal to 65 years of age who have had a cardiovascular event. That is a massive risk factor for that individual. Adverse pregnancy outcomes could include gestational hypertension, gestational diabetes, preeclampsia, eclampsia. We know that women who have had adverse pregnancy outcomes have a twofold increased risk of cardiovascular disease, often at a young age. So it's important to keep that in mind, along with polycystic ovarian syndrome. Again, that comes along with metabolic syndrome and all of the similar risk factors that leads to future cardiovascular disease. Early menopause, below the age of 40, some say 45 years old, is also associated with future cardiovascular disease, as is erectile dysfunction in men, indicates vascular dysfunction. Inflammatory diseases, including HIV, we now know that we have a class 1A indication for statin therapy in individuals with HIV. So these are all risk-enhancing factors. And then, of course, high-risk ethnicity. We talked a little bit about the South Asian population, but also American Indians and Pacific Islanders are very high-risk populations. And then in addition, some procedure imaging-based risk modifiers. We talked about ABIs in the context of type 2 diabetes, but also a coronary artery calcium score. Increasingly, I am using this in my practice, not so much to decide whether or not a patient needs to be on a statin therapy. I usually know if they need to be on statin therapy. It may be to convince them that they need to be on statin therapy, but it also, I find, is very helpful in potentially modifying my LDL goal. So if I was going to aim for less than 70, for example, for LDL cholesterol in my patients with type 2 diabetes and other risk factors, if they have any significant coronary artery calcium or really any calcium at all, I might aim for even lower and being more aggressive. So these are some of the risk factors that I take into account when I'm thinking about how to target and personalize the therapies that I'm going to initiate in my patients with diabetes. And so now let's talk about, well, what do we do? Okay, so we have our patient with diabetes who's sitting in front of us in clinic. We want to modify their risk. We know that just because they have diabetes, they are at risk for future cardiovascular morbidity and mortality. And so how are we going to help them to prevent those bad things from happening? And this is a figure that came from the American Diabetes Association Standards of Care from this year. And it really kind of outlines some of the pillars of management. So we start at the base always with lifestyle modification and education about their disease. And then we think about blood pressure management, lipid management, and agents with cardiovascular and kidney benefit in order to reduce diabetes complications. Now, diabetes complications can be macrovascular complications, and certainly blood pressure management, lipid management, agents with CV and kidney benefit can help to reduce those macrovascular complications. And then, diabetes complications can also include microvascular complications. And here is where glycemic management is extremely important. And I will say that I personally, as a cardiologist, I'm not doing a lot of glycemic management in and of itself. Yes, many of the therapies that I will prescribe, SGLT2 inhibitors, GLP-1 receptor agonists, they will impact that patient's glycemic status, but I'm not prescribing it for the purpose of managing their glycemia alone. That to me is much better handled by primary care clinicians and endocrinologists. I'm certainly not going to get into the business of prescribing or managing insulin. I would be horrible at it. So for me as a cardiologist, I am not prescribing therapies for the purpose of glycemic management. It's incredibly important, but I leave that to people who are far more knowledgeable than I. But in addition to managing their blood pressure, lipids, and these other kind of newer medications, what this figure doesn't include is kidney and liver disease management. And we're going to get into this a little bit. And you might say, I'm a cardiologist. For those of you who are cardiologists, I'm a cardiologist. Please tell me I don't have to manage the kidney and manage the liver as well. And I'm here to say that all these organs are linked. They are all incredibly important to the patient's overall cardiovascular health. And increasingly what we're learning in this kind of increasingly linked world is that if you are diagnosing kidney or liver disease in your patients, the therapies that you would use to help prevent worsening kidney and liver disease are the exact same therapies that are going to improve their overall heart health, which is amazing for patients, but also means that you need to be aware if they have kidney or liver disease so that you can know what therapies will benefit them, not only from their kidney and liver perspective, but also from their cardiovascular perspective. So let's start with the basics. We must always start with lifestyle modification. And so I talk to every single one of my patients about a diet that I recommend for them and also about physical activity. Now, this is not a diet. The diet that I talk to my patients about as a cardiologist is a diet to maximize their overall cardiovascular benefit, not necessarily to maximize their glycemic control, though this combination of kind of dietary patterns that I recommend can also help them manage their glycemic status. And I think that the dietary patterns that have the best evidence are the Mediterranean diet. We know that from randomized trials, from the PREDIMED trial and others, that a Mediterranean diet, which focuses on healthy fats and proteins, non-processed foods, lots of green leafy vegetables, and not a lot of red meat, processed foods, sweets, things like that. We know that can improve overall cardiovascular health and help to prevent worsening glycemic status as well. We know that a low carbohydrate diet, and I don't mean a ketogenic diet necessarily, because we don't know about the cardiovascular safety of ketogenic diets, which is very low carbohydrate, but a low carbohydrate diet in general is important for weight loss for the patients who need that. And then low salt. We know that if you have a high salt diet, you're going to develop hypertension and it's going to lead to all sorts of other badness. So in general, I am promoting a Mediterranean diet that is low carb and low salt for my patients, really focused on eating from home as much as possible, because when you get food from outside, they don't care about you, so they're not going to, make the food with the whole ingredients that are necessary, and really focusing on trying to avoid processed foods. In terms of physical activity, I really stick with what the American Heart Association recommends for everybody, not just people with diabetes. And that is that my patients, I advise them to get at least 150 minutes a week. So 30 minutes a day, 5 days a week of at least moderate intensity physical activity. You could do vigorous if you want to and get away with some fewer minutes, but most of my patients would do well with thinking about moderate intensity. And the way that I describe that to them, people are asking all the time, what heart rate should I target? I find that sometimes when people focus too much on the heart rate, they go crazy thinking about their heart rate, and it can get them very stressed. Instead, I say, I want you to be able to talk but not sing. If you can sing a song while you're exercising, you are not hustling enough. And so you need to just kind of increase your pace or increase your intensity until you can talk but not sing. And then in general, just promoting less of a sedentary lifestyle. Just stand, just move. Any movement that you do is better than not moving. And so move more, sit less. And then a strength training, especially as we begin to talk about GLP-1 receptor agonists, is also extremely important, especially as patients age. So now let's talk a little bit about some of the agents with cardiovascular and kidney benefit. And this is one of the simplest diagrams that I found, again, in the ADA standards of care from this year, that really emphasizes the idea that in your patients with type 2 diabetes, whether they have atherosclerotic cardiovascular disease or whether they're just at risk for developing it, they should really be on both an SGLT2 inhibitor and a GLP-1 receptor agonist. We really passed that time in the medical community where we think patients should be on just one or the other. Truly, these medications, even though it's never been tested in a clinical trial of looking at both versus one or the other, we have very good reason to believe that these are not overlapping mechanisms of benefit and that patients will derive benefit from both of these types of therapies in different ways. And so on the left, you'll see that if they have established cardiovascular disease, they should certainly be on a GLP-1 receptor agonist and an SGLT2. And if they have high risk, they should also be on an SGLT2 inhibitor and a GLP-1 receptor agonist. So this, what I really want to get at here is the idea that it's not really an either or, it's a both, if they can manage both, and if, of course, the access and the cost issue is always there. That will continue to improve over time as we begin to get generic therapies. But if we can start our patients on both, especially if they have high risk, we really want to start doing that. Now, the other thing I do want to mention is, we can talk about sequencing of the therapies of SGLT2 inhibitors versus GLP-1 receptor agonists. Really, it's whatever you and the patient feel comfortable with. It's some amount of shared decision making. But if they really have more of an atherosclerotic kind of profile, or they have high sugars, or they have a high BMI, you may want to prioritize the GLP-1 receptor agonist. Whereas if they have heart failure of any kind, reduced mid-range preserved ejection fraction, and if they have chronic kidney disease of any kind, you may want to prioritize the SGLT2 inhibitors. But remember, there's overlapping benefits here. We know that GLP-1 receptor agonists have some benefit in heart failure with preserved ejection fraction. They also have some kidney disease benefit. We have seen, in a secondary prevention population, just overall mortality benefit with some of the SGLT2 inhibitors. So there's overlapping benefit, truly. And then the one thing to keep in mind is that, the risk of hypoglycemia is relatively low with these agents unless the patients already have very well-controlled sugars and they're on a sulfonylurea or insulin. If that's the case, I will often stop the sulfonylurea because they're not giving you cardiovascular benefit. And if we need to adjust the insulin, I don't do that, as I mentioned. I'm not competent in that. I ask for help, and I've never had the patient's primary care endocrinologist have any issues with my asking them for help and how to do that. So let's move on to lipid management. And here I'm focused on LDL cholesterol, but also don't forget apolipoprotein B. I still think it's incredibly important to be measuring ApoB in these patients, because these patients with diabetes are the patients who are more likely to have discordance, meaning that they could have a high ApoB even if their LDL cholesterol is normal, meaning small but many particles, and that is associated with significant cardiovascular risk. And you want to know if your patient has that, even if their LDL cholesterol is okay. These are from the 2018 cholesterol guidelines. Again, we expect an update in the near future, so this might be this part of the talk may be irrelevant pretty soon. We'll see what the upcoming guidelines say. But all of this to say, I am really aiming for an LDL cholesterol of at most 70, if not lower, in my patients with diabetes, even if they don't already have atherosclerotic cardiovascular disease. Now, that may be more aggressive than many other clinicians are doing. But especially if they have other risk factors, other standard risk factors, or even other more kind of newer risk factors like an elevated lipoprotein a, I might be aiming for an even lower LDL cholesterol. It really is important in these patients who have diabetes to get their LDL cholesterol down. And, these guidelines said, everybody needs to be on a moderate intensity statin. Frankly, I don't think that's enough. I think you need to make sure that your patients get down to the LDL goal that you want them to get to. And a moderate intensity statin might do that, but you may need a high intensity statin. You may need other adjunctive therapies as well to get them there. So I think, again, moving away from just starting therapies, but also getting to the goal that you set for that patient is extremely important. So this is kind of what I wanted to talk about in terms of being aggressive for LDL management. These are the guidelines from the ADA standards of care. And just so that you can see, they're more recent, right? Those are the 2018 cholesterol guidelines that are going to be updated very shortly. These are this year's ADA guidelines for patients with diabetes. And what you can see here, this figure is for primary prevention. They say to use a moderate intensity statin, but you may need to use bempedoic acid or other therapies for patients who are statin intolerant. But if they have any atherosclerotic cardiovascular disease risk factors, any of them, they're aiming for an LDL of less than 70 as well. So again, everything is moving more aggressive. And then the bottom is for the secondary prevention, and they're aiming for an LDL of less than 55, and that is the direction that we should be moving. If your patient has atherosclerotic cardiovascular disease and diabetes, you need to go as low as possible to help to prevent recurrent disease. And you may need more than a statin for that. You may need ezetimibe. You may need a PCSK9 monoclonal antibody or siRNA. You may need bempedoic acid. There are many options out there, and it comes down to shared decision making. And unfortunately, it also comes down to access and cost. But all of these are getting easier to obtain in my clinical practice. It's way easier to get access to these medications now than it was even 2 to 3 years ago. And my hope is that that continues to improve as well. This is just to kind of remind ourselves that triglycerides aren't bad. We still need to be keeping track of triglycerides. And the patients who are most likely to have elevated triglycerides are the patients with diabetes, right? And again, remember that if patients have a totally uncontrolled A1C, it's really hard to get their triglycerides under control. One of the first things you need to do to control your triglycerides is to get your sugars under control. That helps to get your triglycerides under control. But things like fibrates, we have tried over and over again to see if there's cardiovascular benefit, and we have seen none. So you really only should be using fibrates in your patients to prevent pancreatitis. So if their triglycerides above 500, above 800, you want to be thinking about fibrates in those populations. But for omega-3 fatty acids, and specifically those that are EPA only, like icosapent ethyl, we saw in the REDUCE-IT trial that there was a 25% MACE risk reduction in patients who had already had a prior event or who had not had a prior event but had type 2 diabetes. Now, this is a little controversial. There was a little controversy around that trial and whether or not the placebo that was used, which was mineral oil, could have actually potentially had negative effects. And we didn't see benefit with other omega-3 agents like Epanova, though that had a combination of EPA and DHA. So there has been some controversy around this, but in general, if I have high-risk patients, especially those with type 2 diabetes, and they have elevated triglycerides above 150, I am going to think about starting icosapent ethyl, especially if I can get access to it for that patient. And then just to remind ourselves, I do have some patients with very elevated triglycerides, familial chylomicronemia syndrome. These are patients with triglycerides in the thousands. And for them, getting access to some of the ApoC3 inhibitors that are just coming out, these are very new agents, but very effective. And it's exciting to be able to prevent pancreatitis in these patients. Lipoprotein a. I check this once in everyone. Again, lipoprotein a is another type of bad actor, another type of bad cholesterol. It's almost entirely genetically determined. So I find that patients like to know if they have this because they want to be able to tell their first degree relatives. If their Lp(a) in the nanomoles per liter measurement, if it's 75 to 124, that's kind of moderate risk, and that's important to understand. But certainly if it's greater than 125, that means that they have a significantly elevated risk for cardiovascular disease. And that helps me to understand how aggressive, it's yet another risk enhancing factor. How aggressive do I need to be with their LDL and ApoB cholesterol? And how aggressive do I need to be with their other preventive therapies? And then it also helps me keep track of these patients because potentially some of the agents that are, many of which are coming down the pike in the next few years, if they're effective for preventing cardiovascular disease, I want to know which patients to start these therapies on. As ever, blood pressure management is incredibly important. I mean, hypertension is the single greatest kind of untreated risk factor and preventable risk factor for cardiovascular disease, both in patients with type 2 diabetes and without. And so it really is important for us to be managing blood pressure in these patients. It may not be exciting, but it's critically important. And what we learned from the very recent BP Road trial, you'll remember that the SPRINT trial told us that we need to be aiming for a blood pressure of less than 130/80 in most patients, but the SPRINT trial excluded patients with diabetes. So what about our patients with diabetes? Well, that was addressed in the BP Road trial, which included individuals with diabetes who were at least 50 years old, and they were randomized to kind of a more intensive blood pressure lowering intervention of aiming for less than 120 systolic versus less intensive, aiming for less than 140 systolic. And they looked at 4-point MACE, which is cardiovascular death, MI, stroke, and heart failure hospitalization over just 4 years of median follow-up. And look at this, there was a 21% risk reduction with the more intensive blood pressure arm. So understanding this, the most recent blood pressure guidelines said that in our patients with diabetes, we should be aiming for a systolic of less than 130, ideally less than 120, like BP Road, and a diastolic of less than 80. And you can start any of multiple therapies at baseline, but if your patient has any form of kidney disease, albuminuria, a low eGFR, your first line should be an ACE inhibitor or an ARB. So what about kidney disease screening and management? And this is the KDIGO heat map, which I think cardiologists may not want to know about, but it is incredibly important. This isn't actually just the heat map. This is a heat map and overlaid with kind of what to do about patients at these various stages. And this again comes from the CCAM Presidential Advisory from 2023. And what I want to point out here is that the KDIGO risk categories that are based on eGFR and albuminuria levels are linked to the absolute risk, not just for kidney failure, but for heart disease. Whether patients have kidney disease really tells you whether or not they're likely to develop heart disease. And so that's, and all-cause mortality and other adverse outcomes. So that's incredibly important to know and to screen for kidney disease. And so in all of my patients with diabetes, every year, I am checking if their primary care didn't do it, I am checking their eGFR and their UACR. And then the question is, well, what do you do about it? Well, now there's a lot to do about it, and there didn't used to be. And here's what's important for cardiologists. What we do to prevent worsening kidney failure in these patients will also help their cardiovascular health, because all of these therapies do it all. And I think that's incredibly important to understand. So if patients have diabetic kidney disease, meaning their eGFR is less than 60 and they have diabetes, or if they just have any albuminuria, even without diabetes, you really should be starting an ACE inhibitor or ARB therapy. And if they have any type of chronic kidney disease, eGFR is less than 60, UACR is greater than 30, in any way, shape, or form, whether or not they have diabetes, they will benefit from an SGLT2 inhibitor. These patients should be on SGLT2 inhibitors, okay? Now, if they have diabetes and they're on these therapies and they still have some albuminuria, right, then you can also add finerenone, which is a non-steroidal MRA shown to have benefit in the Figaro and Fidelio trials in patients with diabetic kidney disease. And the FLOW trial showed that semaglutide sub-Q up to 1 milligram helps prevent worsening kidney disease and cardiovascular disease in patients with diabetic kidney disease. So there are a lot of therapies that are available, but you notice all of these therapies are also good for your heart, right? So I think there's a lot of overlap there. Lastly, liver disease. So metabolic associated liver disease screening and management. Again, you might say, Neha, I'm a cardiologist. I don't want to be doing all this kidney and liver stuff. But just remember that one of the greatest risk factors for future cardiovascular disease is whether or not your patient has MASLD or MASH. And you can figure out whether or not they're likely to have that. You don't need to do a biopsy. You don't need to image everyone. You can do something called a FIB-4 score. And this FIB-4 score, at least in our institution, the gastroenterologists have programmed it into our instance of Epic. So I do .fib4 calc, and it calculates it for me. It's really simple. As you can see here, you just need LFTs and a CBC, and you can get the FIB-4 score. And I check it in my patients with diabetes and multiple risk factors, multiple cardiometabolic risk factors, hypertension, hyperlipidemia, obesity, and so forth, every year or two. And the thresholds, if they have a score of less than 1.3, they're pretty low risk. If they're between 1.3 and 2.6, they're moderate risk, and I might have to phone a friend to figure out what to do with them. But if they're greater than 2.67, they are high risk, and I refer them to our hepatologist because they need to be monitored very closely, and they might get a fiber scan and other things at that time. In all of these patients where I'm concerned about metabolic associated liver disease, yes, we work on lifestyle modification, weight loss, carbohydrate reduction, exercise, but also GLP-1 therapy. So we know from dedicated liver trials that both semaglutide and tirzepatide have benefit in MASH, and then there are many other agents that are coming down the pike as well. So just to kind of say, okay, there's a lot that we just talked about, but does this work? If we manage all these risk factors for our patients with diabetes, does that actually do anything for them? And I'm here to say yes. So this was the STENO2 trial, just a beautiful trial that was done eons ago. You can see it was started over here in 1993, started a long time ago. It was done, this landmark trial done in Denmark, and they assessed the efficacy of a multifactorial intervention on cardiovascular outcomes in patients with diabetes and who also had microalbuminuria or albuminuria. And what you can see is that they randomized patients to an intensive, multi-risk factor intervention versus standard of care. And you can see here on the right, kind of the treatment targets for the different groups. And they said, if we try to treat all these risk factors, again, these are old thresholds, we're more aggressive now. And yet you still saw almost a 50% reduction in cardiovascular disease and a 70% risk reduction in heart failure. So anything is better than nothing. Addressing these risk factors really does help our patients with diabetes, but things are only getting more complicated than they were in the 90s. And now we have patients who are very complicated. They have multiple clinicians, as you can see here, and they can fall through the cracks, right? Care is getting more and more fragmented. Everybody else thinks that the other person is starting an SGLT2. The nephrologist must be starting, the cardiologist must be starting it. Well, the endocrinologist didn't start it. It must not be important. No, these are important medications that fall under all of our categories. And if we don't all take ownership, every one of us take ownership and say, I'm seeing the patient today, that means I have to start it today, it won't happen. Also, if we don't have a way to kind of communicate and have more interdisciplinary care, these patients are going to fall through the cracks. And so this is something, again, that was really promoted in the presidential advisory for CKM. And I think we're going to be hearing a lot more about it going forward. This idea of interdisciplinary care models for CKM syndrome. And you can think about this in various ways, but however you think about it, it really would be helpful to have some kind of coordination role, somebody, right? Whoever that point person is, it could be a nurse, it could be a pharmacist, it could be a medical assistant, it could be anybody. Ideally somebody who can prescribe, but it doesn't have to be, who is going to really take kind of ownership of coordinating care for that patient, not just getting their appointment scheduled, but do they understand what medicines they're supposed to be on? Do they understand what therapies their different clinicians have prescribed and why? Do the clinicians know what everybody's doing? And so to be able to coordinate all the clinicians and the patients and their access to care and make sure they're adherent to therapies, it really is helpful to have this kind of role of a CKM coordinator. And I think we're going to be hearing much more about that going forward. So in conclusion, patients with diabetes are at very elevated risk for additional cardiometabolic disease, and aggressive risk factor modification is warranted and it works. And interdisciplinary care models are really going to be necessary to holistically manage these patients in an evidence-based way. And finally, prevention is cool. So thank you so much, and I look forward to the discussion.
Well, Neha, that was an amazing presentation. There's so much here to cover. It's hard to even know where to begin. I'll open it up first and just tell the audience that we have opened up the chat, and I'll be looking at the chat to guide the Q&A session. So thanks to those of you who have already put in questions for us. And I have some of my own to add in. But let's start off perhaps with maybe an easier one, which is how do you incorporate the expertise of dietitians for individualized dietary modification?
Thanks,
Maybe not
thanks,
so easy.
Anne-Marie. Yeah, I was going to say it should be easy, but alas, I have not found it to be as easy as I would have hoped. So this is an excellent question that somebody put in the chat about how do we incorporate kind of individualized dietary modifications and dietitians' expertise. First of all, it is absolutely true that it is impossible to do a really good job of cardiometabolic disease prevention in those with or without diabetes without having access to great kind of dietary expertise and support. Unfortunately, I think the reality of access to such care is somewhat limited in the US at least. So what we have found, so we have a multidisciplinary cardiometabolic clinic. And that incorporates clinicians who are cardiologists, endocrinologists, nephrologists, hepatologists. But what we don't have support for is to cover a dietitian, and that's what we would really like to have, and that's on my like first up on my wish list. And I think part of that is because the reality of finances is such that, at least for us, we found that if we can't fully cover, like fully fill the schedule of a dietitian from the get-go, then we can't make it even cost neutral to hire a dietitian just for our program. And so there are obviously dietitians within our health system that we can refer to. But frankly, what we found is if you're just referring out to a dietitian, you don't know who you're going to get, you don't have a conversation with that person, it's really hard to collaborate on that patient's care, because they might think, oh, really what we should be talking about is carb counting and their diabetes management, but really what I wanted them to focus on was their triglycerides of 1,000 and how it really needs to be a low fat conversation, and so forth. So it's just an example of how it really helps to have a conversation to tailor the advice that a patient's going to get. So I wish that I had an easy answer for this. I don't yet, but as soon as we figure out how to make it financially viable to have a dietitian within our clinic, I would love to come back and report to the group.
Ours is funded all internally because we couldn't sort out the finances with billing. But you bring up the important point, which is, there are different goals that we have for dietitian, and you really need to have a dietitian who you're aligned with in the prevention space. So we're going to talk about heart health, or we're going to talk about weight loss, or for the severe hypertriglyceridemia, we're going to talk about really low fat to prevent pancreatitis. So hopefully we can have continued payment reform and maybe some better models of care. While we're talking about triglycerides, since I mentioned triglycerides, you talk about using EPA, prescription EPA in the form of icosapent ethyl. Somebody said, well, what about EPA only supplements? Thoughts on those? Is it just as good? When would you use EPA only versus the prescription form?
And nobody has more expertise on this than you. So I'm going to speak and then ask you to comment on this as well, because you've written extensively, I thought extensively about kind of over-the-counter supplements. So here's my short, kind of simplified approach. I know based on the Reduce It trial that icosapent ethyl, which is branded as Vascepa, is associated with a 25%, leads to a 25% cardiovascular risk reduction in patients who are secondary prevention or high risk primary prevention with type 2 diabetes. I know that that is the benefit associated with that agent, and therefore that is the agent that I try to use. The problem with over the counter is you really don't know what you're getting, right? Because these are not FDA regulated supplements. They're supplements and they're not FDA regulated. And so you don't really know what you're getting. And a lot of the time, these over-the-counter supplements are giving you EPA plus DHA. And as far as I'm aware, we've never seen cardiovascular benefit when you have the combo of EPA and DHA. For example, what we saw with the Strength trial and others, you don't have that benefit, but most of those supplements are EPA plus DHA. Now, if you could find an EPA only supplement, you still don't technically know if you're getting that benefit. So for my high-risk patients where I want to know what it is that they're getting, I would still like to try and get them icosapent ethyl. I understand that there are significant access issues because of the cost of the medication, but hopefully that will start to improve because generics are already coming on the market.
Perfect. I think the only thing I would add to that is, over-the-counter medications are actually FDA regulated. Supplements are treated like food. And so even if the bottle says you're getting X number of milligrams, there's very little regulation to ensure that there's consistency from batch to batch, that there are not other toxins. The reasons why you have fishiness after you take a supplement is because it's starting to oxidize, and the purified EPA that you get in prescription form is not. So, it's probably best to stick with prescription, but if that's all you have available, seems reasonable. So let's pivot a little bit. We talk a lot about lifestyle. And, there's, in an ideal world, all of the patients that we talk to about lifestyle make all of these changes. I think there's sort of two questions are, how do you motivate people to actually do it? And then second, how long do you give them before you say, okay, this didn't work, now we're going to need to do something else?
Yeah, these are excellent questions. And this is probably the thing that I get asked the most, is like, how do you actually achieve behavior change? And not to say that I'm a world expert on it, I'll give you my approach and see if this resonates with you and everybody who's watching, what works in your clinical practice. So the way that I approach lifestyle change and that to me, again, just to emphasize the importance, that is the base case, right? That is, if I'm starting any medication for any kind of cardiometabolic disease, whether it's obesity, diabetes, hypertension, hyperlipidemia, I'm always starting with diet and exercise, or diet and physical activity. Some people don't like the word exercise. So I'm always starting with diet and physical activity, and that is kind of at the core of everything that we do, because all of these therapies are supposed to have been tested on top of those foundational strategies. So in terms of motivation, I start from the perspective of a cardiologist, which you wouldn't believe actually how influential that can be for patients. This isn't just somebody telling them, hey, you should eat healthier and hey, you should exercise more. This is, they've come to a cardiologist, which in and of itself can be, stressful. They're already thinking very seriously about their heart health. And if a cardiologist tells you, I'm telling you to do these things, not just because of some kind of superficial reason, this is about your heart health. We are trying to prevent heart attacks and strokes. That is a very helpful message, I think, for people to receive. The second thing is I try to find people where they are, right? So if you tell everybody to get to the AHA recommendation starting tomorrow, which is 30 minutes of moderate intensity physical activity 5 times a week, but you have a patient in front of you who's elderly with HFpEF and short of breath and doesn't even move for 2 minutes a day, you're not starting where they are. And so where I try to really go is anything is better than nothing. Anything that you do more today is better than what you did yesterday in terms of what you're eating and eating kind of whole foods rather than processed foods in terms of physical activity. The other thing I try to do is it's overwhelming to have people make a ton of changes at once. So I focus on one diet thing and one physical activity thing every time I see them. I make a list of, they tell me everything that they generally eat or drink in a day. They tell me all the physical activity they do or don't do. And we say, okay, here are some options. Pick one thing that you want to work on for next time. And next time I see you, because I write it down in my note, I'm going to talk to you about it. And that accountability is actually really, really helpful as well. So these are some of the strategies that I use. And I've anecdotally, I feel like it's working, but I'd be interested to hear from others, if you try this approach, what that does for you all.
And then, so how long do you give someone to sort of, we always say like start with lifestyle, but how long do we give them before we start lipid lowering, additional diabetes?
It's very individual specific. So there are individuals who, and it just depends on how off they are from where I want them to be. If I have somebody whose LDL cholesterol is 180 and they're a secondary prevention patient, they're going to get all the things that day, right? They're going to probably get combo lipid lowering therapy, plus they're going to get diet and exercise. But if I have somebody who's, say, a 35-year-old whose LDL is 130, they're worried about their risk, they don't have the healthiest diet, and they don't exercise too much, their short-term risk is low. I don't emergently have to get their lipids under control. And it could be motivating for them to help to work on diet and exercise first. So then I'll usually give people like 3 months. Much longer than 3 months and they've forgotten who you are and why you're there, right? So if you go much longer than 3 months, and again, I say all the time, prevention is a short-term follow-up game. You can't do like, bye, I'll see you in a year. But I do like short video visits at 3 months, like 5 minutes. Doesn't even take 5 minutes, and that's that. And you can bill for that, right? So the health system doesn't mind when I'm stacking like 10 video visits in an hour. Because I'm following up on all of these things to make sure that people are achieving their goals.
Yeah, and I think there's some patients who you maybe don't feel that confident in their ability to make lifestyle changes, or whose LDLs, A1Cs are so over the mark that it's not going to be enough. And so what I'll tell patients is, let's get you on something now and get you into the green zone. And then as you make the lifestyle changes, we can see if we can back off.
Yeah, also a great approach.
Part of that is many of my patients just are not successful in making those changes.
That's absolutely true. And you can sometimes get a sense of that early on. And so it is tailored. I think to your point, it's tailored to the person in front of you.
So let's say it works. Let's say somebody, high cardiometabolic risk, sees you, makes a bunch of changes and their A1C is down to 6. Somebody asked a question, would you start an SGLT2 inhibitor then? Or a GLP-1?
Once their A1C has come down?
Yeah, if their A1C gets down on dietary modifications alone, what do you do with pharmacology?
Okay, I love this question. This is a superb question. Whoever asked it, good on you. Here's the important thing. I am not starting GLP-1s or SGLT2s as a preventive cardiologist. I am not starting GLP-1s or SGLT2s for the purpose of glycemic control. I am starting it for the purpose of atherosclerotic disease risk reduction, heart failure risk reduction, kidney disease risk reduction, and for some patients for obesity, for GLP-1s for their obesity as well. And it is very clear that the cardiovascular and kidney benefits of these agents is not reliant upon the amount of A1C lowering. And so if you have a patient with type 2 diabetes, and that means that they've had an A1C of greater than or equal to 6.5 at any point, you can be kind of in remission, but if you've ever had an A1C of greater than 6.5, especially if it wasn't in the context of like steroid use or something like that, you have type 2 diabetes. And therefore, there is some risk associated with that. When you have a low A1C, that's good for your microvascular. That's good for your microvascular health. And lowering A1C is important for your microvascular disease risk reduction. But your macrovascular disease risk remains, and you still need to treat that, and you still need to be aggressive about treating patients who have type 2 diabetes, no matter what their A1C is. So I don't base GLP-1 and SGLT2 initiation on their A1C, and I don't base it on whether or not they're already on metformin. There was an old recommendation that you had to be on metformin before, and that helps in no way, shape, or form. You don't have to get them on metformin first in order to start these life-saving therapies.
So then it's just based on, do they have ASCVD or multiple risk factors? That's your decision point?
Exactly. Now, because all of the trials for if they have ASCVD, then yes, absolutely. Many of the trials for GLP-1s and SGLT2 showed in a secondary prevention population. But even, we have some data for in a high risk primary prevention. They have multiple risk factors. They're high risk in some way. You still want to be preventing atherosclerotic cardiovascular disease, and I start SGLT2s and GLP-1s in those patients as well.
Now you said I'm going to just follow up here.
Yes.
You do them both at the same time? Do you start one first? How do you sort of gate those?
Great question. So this is what I do in my clinical practice. If I think that a patient is at elevated cardiovascular risk, or they have heart failure, at high risk for heart failure with preserved ejection fraction, or they have kidney disease, or at high risk for kidney disease, SGLT2s and GLP-1s help all of those things. All of them. They both help all those things. It's amazing. So I want to get patients on both. And then the question is how to do that. I typically, unless the patient is very kind of proactive and we think they can handle getting on many therapies at once, because often these patients, I'm seeing them, I'm also getting them on a statin, or I'm also getting, you have to kind of like, you have to match.
Pick your battle.
Yes. Match how aggressive you are in starting things to how much the patient can take before they just get overwhelmed and never come back to you, right? Because I'm also talking to them about diet and exercise and all those things. So I will more often than not, I'm not starting the SGLT2s and the GLP-1s at the same time. I'm sequencing it, but remember, I'm seeing them frequently. So I'll be touching, and I'll let them know it's coming. So I'll say, look, here, because you just had an MI 3 months ago and your BMI is 48 and you also have some kidney disease and I can see that you're pretty short of breath, I'm going to start with a GLP-1 receptor agonist. But just so you know, here's what you expect, here's how you start it. Just so you know, when I see you in 3 months, I'm probably going to add on an SGLT2 inhibitor because that's going to help prevent your risk, or help worsen your prevent worsening of heart failure, kidney disease, and so forth.
Great. And I think it's helpful to tell our patients that these drugs keep people off of dialysis. We've got
Yes.
what's maybe a win for cardiology is we've done such a good job at taking care of people with heart attacks that people are now much more afraid of dialysis than they are of a heart attack. And so I find, that the other benefits of these therapies to be really motivating as well.
Absolutely.
Also helps because if we tell them it helps their kidneys, it's a little reassuring when they see bumps in their creatinine after initiating therapy, for example.
Yes.
Somebody asked a question. I'm going to make it a little bit more higher level, but the case here was about a patient with high LPA whose LDL was low, but had progression of coronary calcium. So I'm going to pivot this and say, is there any clinical utility for reassessing coronary calcium in patients who are on lipid-lowering therapy? And why not? And if somebody happens to get a follow-up CAT scan and you see it change, how do you interpret that to the patient?
Oh, so good. I love this. This is so much fun. So yeah, excellent question. So and you have so much to say about this as well, so I can't wait to hear what you have to say about this. So coronary artery calcium scores are most useful, for the guidelines if you're not sure about whether or not somebody should initiate on a statin or how aggressive you should be about their preventive therapies. But also if the patient is not sure and you're trying to convince them, it can be very motivating if they see calcium. And so oftentimes we're trying to decide whether or not to start lipid lowering therapy, and that's when calcium scores are most useful. Personally, I am also now using calcium scores, not just if I'm trying to decide whether or not to start a patient on statin therapy. It's usually the answer is yes, if there's a question that you're going to start them on statin therapy, but more to kind of tailor their LDL goal. Because if, for example, if they're 45 and they already have a calcium score of 5, that is not right. That is like 99th percentile. And I'm going to aim for an LDL of less than 50. That's not in the guidelines. That's what I'm doing it to, because I know the lower the better. So that's how I'm utilizing it. Once you have gotten them on appropriate therapy and you have gotten their LDL to goal, I really don't see benefit in repeat coronary artery calcium testing. And I get asked this by patients all the time. They're like, my last one was a year ago. It's time for another one. First of all, no. The earliest, if you were to do repeat testing, the earliest you would ever do it is 3 to 5 years. But you really have to think about what it is that you're looking for, because you've already made your decision about lipid lowering therapy. And we know that statin medications, for example, will stabilize plaque and increase the calcification. And therefore, these patients will see their calcium scores go up, which will freak them out. And then you have to sit and explain, no, 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 we are hardening the soft plaque. We are stabilizing things. We know that this is a good thing for you in the end. It can just be more confusing and scary for patients, though, to see their calcium scores go up. So long answer short, no, I generally don't check calcium scores again. What do you do?
Well, I don't repeat coronary calcium scores unless somebody has chosen not to start on therapy.
Right, right.
We know that CAT goes up even in patients with very low LDL cholesterols in whom have very low risk of recurrent events. And my analogy for this is like an iceberg that when you've been on, before you're on a statin or before you're on cholesterol lowering, the presence of a little bit of calcium is like seeing the tip of the iceberg, but it's actually the stuff under the water. It's the non-calcified plaque that causes disease.
Yep.
Now, the longer you're on a statin, the more of your iceberg is out of the water. And so there's actually not as much non-calcified stuff to get the boat to sink you. And it's not the calcified stuff that we're afraid of. So it's not a useful measurement once you've already been on lipid lowering therapy. It goes up regardless of what's happening to the non-calcified plaque. So you do it once, you don't check it again. If somebody happens to get a test again, you say it's okay, that's expected.
Yep.
And then what we know from intravascular ultrasound studies and serial imaging studies is that if we get LDL cholesterols less than 55, you actually start to see regression of non-calcified.
Yes.
And that's really and that happens over time. So we tell people, I tell people, we get you down low, we're going to keep you there. Maybe in the future, we'll be looking at serial CT scans or other things to sort of better personalize serial changes in plaque, but not yet ready for prime time.
Well, and just to kind of echo your point, Amory, you brought up something that patients ask, I feel like every day in clinic, which is, can I make this go away? Can I make this plaque go away? And so your point is, I think, very motivating to patients to say, actually, yeah, if we get your LDL very low, no matter how it is that we do it, no matter which medication we use, it doesn't matter how you get your LDL down. If your LDL goes down very low, especially less than 55, even more if less than 30, then we know that you can begin to regress some of that plaque. And you're certainly not developing more plaque, which you would otherwise do because that process has started. You're certainly not developing as much plaque as if you didn't get your LDL very low. So I think that can be very motivating.
Well, speaking of motivation, I'm just going to end with one question, which is, Neha, you started the prevention program at Duke before you became faculty. We didn't have a preventive cardiology program at Duke. We had regular cardiologists that saw everybody. How do you motivate a health system to care enough about prevention to create a cardiometabolic program?
Oh, okay, so good. So a couple of things. One is that I think that the awareness of prevention being important is increasing just more broadly. The preventive space is exploding, right, in terms of the therapies that are available. And so I think it is easier now, and also in the context of like the CKM movement and everything, I think people are becoming more aware. I think it is easier to make your case, A. B, our clinic didn't cost the health system much money at all. So we are operating within the confines of a fee-for-service system that we are at Duke. And so this is really a coalition of the willing, of clinicians who want to try to coordinate care and practice together, but we didn't kind of cost the health system more money. So I think that's another important point. The third thing is that if you are trying to make the argument, I have a whole separate talk on like how you create these clinics, and would love to talk to people about it if you're interested. But when you're trying to have these conversations with your health system about creating multidisciplinary clinics, which I think is really important, what you want to do is make the financial, it's a business case, right? So what you want to do is make the financial argument that not only, especially for systems that aren't taking on the risk of the population. If you're taking on the risk of the population, that's a lot easier because you're going to make the population healthier. That's going to save the system money. If you're a fee-for-service system like ours, where that's not the case, what you can say is we actually generate a ton of revenue for the health system because of all the testing we ordered. How much did we talk about CT scanning and CAC scoring and echoes? And they're all coming from our clinic, right? We are ordering tons of testing. And so when you're making your financial argument to your health system, please make sure you include all of the revenue that ends up being generated and kept by other areas, but it's coming from you. And I think that's a really important point.
Well, that's fantastic. Neha, there's a million more questions that I could ask and things we could talk about. I'm sorry to the audience if we weren't able to get to your specific question. We did our best. Thank you so much for joining this ASPC CardioCore lecture series. We will be having more over the coming year. If you're not a member of ASPC, join us. You don't have to be a cardiologist. You just have to do or care about preventing heart disease. So come join us at the ASPC, including our annual meeting this year, and see even more great lectures at future CardioCore. Thanks for joining us, Dr. Pagidipati.
Thanks so much.